My main area of research is in gynecological oncology, so I've been particularly interested to hear the new developments in the treatment of ovarian cancer, which is the clinical area in which I work most often. There have been some very interesting data presented, particularly in relation to the trial conducted by the Gynecologic Oncology Group, Trial 218, using bevacizumab in combination with chemotherapy for the first-line treatment of ovarian cancer. Well, this trial took women who had undergone surgery and then normally would have chemotherapy, and it was a trial that had three arms. The two experimental arms included bevacizumab, either with chemotherapy or with chemotherapy and then as maintenance. And the main findings from the trial were that patients who had bevacizumab given with and after chemotherapy, so as maintenance, had a longer progression-free survival than those women who had standard chemotherapy. The magnitude of that difference was about 3.8 months in terms of the progression-free survival. There wasn't as yet any difference in the overall survival, but the data are really rather immature at the moment to know whether there's going to be any significant effect on the overall survival. So what that means is that the treatment causes women to remain in remission for longer, but we don't yet know whether their long-term survival is going to be extended. Nevertheless, it's an important finding because it tells us that this drug, bevacizumab, has activity in ovarian cancer. We've suspected that for some time, but this is the first randomized trial that has really shown the activity of this drug in ovarian cancer. We all hoped that the result would be positive, and it wasn't surprising in the sense that we knew that ovarian cancer is very much driven by VEGF, and angiogenesis is an important component in the development and progression of the disease, so that inhibition of angiogenesis by bevacizumab, we hoped, would control the disease, and indeed that's what it's shown to do. How that fits into clinical practice is, of course, a very different matter, and I think it is really too early to draw conclusions, because what we're seeing at the moment is an extension in the time before the disease comes back, but the cost of that is that women have to undergo 15 months of 3-weekly treatments with an expensive agent, bevacizumab. So I think we have to wait until, firstly, we get the mature results of overall survival to see whether there's any difference in overall survival before we can make a decision about whether that really becomes a drug to use in this group of patients. Having said that, there's no doubt in my mind that this drug is going to be valuable in the treatment of patients with ovarian cancer, but it may be that we will see a better use of Avastin in the later stages of the disease in recurrent ovarian cancer. We certainly need to do more studies to find that out. The survival results should be available, the mature results should be available in another 18 to 24 months, I would think, looking at the rate of events that are occurring. So that will give us some firmer data. But I have to say that my own impression is, from what I saw today, that I don't think there is going to be a significant improvement in the overall survival, which means that we will need to think about where the best place for bevacizumab is in the management of ovarian cancer. Well, the PARP inhibitor drugs really, I think, have been one of the most exciting areas of development in the treatment of ovarian cancer. We first started to look at PARP inhibitors in a relatively small group of women with the BRCA gene mutations, the BRCA mutations, and we now know that many of these women will respond very well and for quite some time to quite simple treatment with oral PARP inhibition. What we have seen from the data presented at ASCO this year is firstly a confirmation that that occurs. We've seen different PARP inhibitors from different companies being used, producing similar results. But we've also seen more data on women who have not got BRCA gene mutations, but have a relatively common type of ovarian cancer called high-grade serous cancer, that have many of the phenotypic features of BRCA mutation patients, principally that they are very sensitive to platinum-based chemotherapy, and they also seem to be sensitive to PARP inhibitors. So we heard at the meeting for the first time that some of these patients who do not have the BRCA gene mutation respond to PARP inhibitors. Now, if this is confirmed in further studies, it will greatly broaden the scope of activity of these drugs, in the sense that we will be able to use these drugs in a much greater percentage of women with ovarian cancer. It's difficult to know exactly what that percentage is going to be, but it could be in the region of about 40%, and that would be a very significant step forward.